So again, welcome back. And in this session, we're switching our focus to MRD as a surrogate endpoint in acute lymphoblastic leukemia. We're going to, as we've done in the morning sessions, try to highlight the issues, the barriers, the opportunities to address those barriers to move forward on more effective MRD validation in this area. We're going to start our session with a presentation from Gerald Radish, the director of the Molecular Oncology Lab at the Fred Hutchinson Cancer Center. After Dr. Radish's remark, we have a panel of 4 members who will share their perspectives on this same general topic, and then again we're going to try to leave some time for both discussion with the panel and discussion with all of you. After we hear from Jerry, we'll turn to Ashley Ward, Medical Officer in the Office of Oncology and Hematology Products at FDA, then Janet Franklin, Executive Medical Director at Amgen, and Don Berry. Don, thanks for joining, Professor in the Department of Biostatistics at MD Anderson, and finally Wendy Stock, Professor of Medicine at the University of Chicago. So let me turn right to Jerry.
Great. Good afternoon. Thanks for the organizers for inviting me. I've been doing MRD my whole professional life. It's coming up on the anniversary of my 30th PCR in the lab, 30th year of my first PCR. And John, no need to send flowers. A card will suffice for that. And I've been writing, in typical grantsmanship stuff, forever, that the reason to study MRD was that someday you'd be able to use it as a surrogate and make drug trials more efficient and the like. So thank God you've invited me to this talk before I retire or die. So this is just a reminder of what we're talking about here. So if I'm an average ALL or AML patient, I walk into the emergency room and I've got about 10 to the 12th leukemic cells, somewhere between a billion and 1,000 billion leukemia cells. And so after induction therapy, when the pathologist looks in the microscope, there still might be as much as 10 to the 9th leukemic cells left over. And if you look at the other things that you can do, cytogenetics, FISH, flow, PCR, and now next generation sequencing is probably about less than that. MRD, minimal residual disease, still means about 1 million cells. Now, we talked about what's in a name earlier, and I'm kind of on a one-man rant to change what the acronym means from minimal residual disease to measurable residual disease. Because when we first started this thing, we did PCRs in water baths. That's right, I actually did water baths and then ran a gel, and it was there or it wasn't there. You couldn't quantitate it. Now you can actually quantitate it. Now you can measure. And I don't know about you, but unless you're an astronomer or a Donald Trump, 1 million things is not minimal, right? Well, actually, I might want to walk it back from that last comment. he might be happy with 1 million. And so it isn't minimal. And the other thing is that the implications of minimal residual disease is that there's a minimal risk. And I think what we're all showing is that minimal residual disease is not a minimal risk. It is something that's major. And so I will try to change it as the lingo. The ways to measure disease, we can do flow cytometry. As you have heard, it's fast, it's fairly sensitive, it varies hugely from lab to lab, and how to interpret MRD is more of a religion than a science by flow cytometry. You can PCR immunoglobulin or T-cell rearrangement. That's pretty sensitive. It takes a heck of a lot of time and energy. It's just very labor intensive. Next generation sequencing, I think, is going to win the day. It's going to be more standardizable. Right now, it's a little bit more expensive. That will come down, as we talked before. And I think there's some evidence coming out now that will be coming out shortly that maybe frequent assays with a more sensitive assay from the blood may be giving you as much information as the bone marrow. So hopefully we'll be able to switch like we did in the CML and just never do bone marrows anymore. There's a fair amount of data for MRD detection, and most of it comes from pediatrics, where the pediatric groups are always, they do the same trials, they cooperate, they have the same drugs, they do great stuff. And you can see here you can either look at overall survival or disease-free survival based on MRD cutoffs. You can see a nice splaying there by level, which is exactly what you'd think if that the early burden of disease has to do with overall survival. In adults, there's much less data because we tend to do things in smaller trials and there's less patients, and we change therapies every 5 months. And so it's hard to know what that means, but you can see you get the same kind of data looking at molecular presence or absence of MRD. But we decided that we would, because of the possible heterogeneity, to look to see whether or not, if we looked at all the really tractable studies out there, could we do a meta-analysis to see what MRD really looks like in adults and compare it to pediatrics? So this was a huge team effort. This was FNIH, Greg back there, NCI with Kim. Don did all of the statistical stuff. So that's really his baby. My role on this is I was kind of the MRD historian on this. And so this is really all Don's data. And Don, I hope I don't trash it here. But thinking about it, we're running out of time. Don, we're going to skip your data. It's like earlier this morning. No, so what we did is we had two different reviewers go into the literature and look at publications that mentioned something about MRD in the title. And we had, you can see, 19 pubs in adults, 31 in pediatrics, 7 mixed, 62 pubs altogether. But then we kind of reviewed and did some exclusions, which I'll show. And at the end of the day, we've got 39 publications with almost 14,000 patients to choose from. So we did separate analysis for adults, pediatrics, and mixed. Again, I'm using we in the imperial we, Don and his group. The primary endpoints we looked at was EFS at OHS. Don did Bayesian hierarchical modeling, random effects models, and you can see the types of subsets we looked at to see whether the heterogeneity that's out there, how you measure MRD, when you detect it by the end of induction, consolidation, what the cutoffs are, whether the data is from a randomized trial or just a phase 2 trial, whether any of that makes any difference at all. And the answer is pretty much not. So this is looking at EFS and in pediatric ALL, and you can see those who have MRD and yes or no at the end of induction or consolidation with a hazard ratio of 0.23. And if you look at adults, you find that the hazard ratio is remarkably similar. If you look at overall survival, again, big difference, hazard ratio of 0.28. You look at adults, 0.28. Now, the difference is the curve shift, right? Because adults and pediatrics, they do better for a variety of reasons. But if you look at the effects, what it means to be MRD positive or negative, the magnitude of the effect's the same, right? So that's really pretty reassuring, actually. And then, Don, these beautiful plots where you look at every individual study, the event-free survival, and look at the hazard ratio and the boundaries. And you can see the boundaries are bigger or smaller depending on the sample size. The bottom two are the standard and the Bayesian summation of all these effects, and they're pretty much spot on top of each other. And in adults, pretty much the same effects. So with amazing consistency across studies. And then we looked at whether it made any difference, adult versus pediatrics, flow versus PCR. And you can see pretty much all of those point estimates and boundaries line up exceedingly nicely. So I would think that if you were a betting person, you would say that MRD is a pretty darn good estimate of your outcome, especially relapsing event-free survival. So we know now that multiple studies show that MRD is associated with relapse rates and event-free survival. Of course, we have the usual caveats that we always want to put in, different adults versus peds, different regimens, different measurements. However, it seems like the signal to noise is a huge signal, and the noise doesn't account for much. So I think it's an exceedingly strong signal. And the question then is, of course, can we just go ahead and use it now as an efficacy to either promote drugs or filter out new drugs in trials? Now, one thing I think you have to think of as a surrogate, at least in my mind, is MRD is not a normal biomarker associated with disease burden and response. It's a direct measure of the disease response. It is the disease. It's just another way of counting. We're not talking about serum porcelain levels or something and seeing whether it's associated with relapse rates. This is the disease, it's right there. And to bring this forward, what limitations do we have to run through? Well, can we use the type of data we have in here where it's a combination of randomized trials and phase 2 data, or can we just go with what we've got? One thing is, do we need to consider surrogacy different in high and low risk settings? We've been talking it as one thing, but it seems to me, as a clinician, that the bar should be different for different clinical situations. If you have someone who has a very good outcome, then the standard of using something as a surrogate and jumping into a trial is much different than a lot of the adult leukemias where there's nothing that works well. And there, I would say your bar is pretty low because you need to get things in to try. So I think that we have to think of this whole surrogate association not as a fixed bar, but as a moving bar depending on the population we're dealing with. And the other last thing is, does CML offer a model? Now, I'm mostly a CML molecular biologist and doc, and so I think it's actually very education to show what happened in CML and how fast that disease changed with monitoring. So the original IRIS trial was started in 2001, published in 2003. At that time, we also published a paper associating molecular response by PCR with outcome. That was done retrospectively. The study was done, the samples were found, we did the analysis, we looked back at it, and we developed this term called MMR, which is a 3-log reduction. That did not come off of a mountain on a stone. We just retrospectively looked at the data and say, look, if you have a MMR level at 12 months, the survival split, right? And we never expected, we invented the term MMR, Tim Hughes invented it. We never expected it to stick. We just needed something for the paper, right? Turns out then, everyone started looking at their retrospective data, their phase 2 trial data that they'd already done, a couple of ongoing phase 3s, and everyone found it worked, amazingly enough. Different types of assays and the like, if it actually worked. By 2007, the nilotinib and dasatinib phase 3 trials used MMR as a 12-month endpoint. So it turned a 5-year trial. The endpoint was MMR and CCIR at 12 months. They hadn't many major randomized trials. It was basically the data was compelling enough that it stuck. The paper was published. It made it into ELN, EMR guidelines early enough. Now there's data looking that you can actually see the effect back as close as 3 to 6 months and tell who the people are. And it's basically now driving all of the molecular studies that are done. All the new drugs that are done uses MMR at 12 months. There are studies done where we look at molecular responses as a criteria for switching at 3 months. We look at it as a way to move people to change drugs to try to drive them from a major molecular response to a complete response. And based on all the discontinuation trials, these are all based on molecular tests of the peripheral blood only. So I would like to posit that in the future, in the near future, like why not now, we can do similar stuff in ALL, move 5-year, 10-year trials into 3-month, 6-month trials to bring in new drugs. Sure, we have to follow these patients out longer to make sure that it sticks. But as far as an early signal of disease response, this seems to me as a pretty darn robust measure. Thanks.
All right, thanks very much, Jerry. So next is Ashley, and again, if you all feel comfortable just sitting there for the remarks, that's great.
I'd like to thank the organizers of the conference for inviting me to participate in this panel discussion, and especially to Jerry Radich for the excellent summary we just heard of the state of MRD in ALL and the evidence supporting the use of MRD to predict survival in that disease. You know, ALL is a really great disease for discussing this topic today for a couple of reasons. The first is that, as Jerry pointed out, we've been assessing MRD and ALL for a long time now, and I'm, as a pediatric oncologist, I'm particularly proud of the role that we played in getting that kicked off, but we've gotten really comfortable in using MRD in ALL, typically to guide treatment decisions, but we all are familiar with the assays and the methodologies, even as they evolve. It's just part of the conversation for people treating ALL. You know, the paper that was cited in the last session from the American College of Pathologists is different for ALL. The data that they cite in that paper is different for ALL than it is for the other diseases. In ALL, you know, a third of the labs are testing for MRD comfortably, and all of them can test down to 0.01% with a sensitivity of 0.01%, which is, you know, better than it is in other diseases. So we've come a long way from that perspective. But there's not been as much in the way of drug development for ALL as there has been in CLL and multiple myeloma. So it's a disease that's sort of ripe for taking advantage of the data that's been collected. And I just wanted to point out that, particularly from a regulatory perspective, it's as we proceed, it's very important to speak precisely about the way in which we're using the term surrogate endpoint. And we've talked about this ad nauseum today, but there's surrogate endpoints that are reasonably likely to predict clinical benefit, and those, that data can be used in certain ways. From a regulatory perspective, it can potentially be used to support an accelerated approval. The regulatory pathways that we have to assess that data are very flexible. And then separately, we've been talking a lot about validating surrogate endpoints and all of the various processes that have to, and the complex processes that have to occur in order to validate a surrogate endpoint. And those are two different conversations that are happening simultaneously. And as we are talking about actual drugs and actual clinical trials, it's important for us to be clear about which way we're talking about MRD as a potential surrogate endpoint. And we get asked a lot about what are the next steps, and I think particularly when you have data supporting the prognostic value of MRD and ALL, what are the next steps? What should sponsors be doing with respect to advancing this as a potential regulatory for potential regulatory purposes? And the first request we have is just to collect the data and collect it in a rigorous way. We see a lot of missing data, and that's problematic in terms of deciding how to proceed. And so we urge people who are running these trials to collect the data in as rigorous as way as possible, and make sure that your analytics are that you understand how to interpret the data that you're getting. And then, there are several ways to bring data forward to the FDA, and I just want to give a brief reminder to those of you who are potentially thinking about doing that. There is the formal biomarker qualification program, which we haven't spent much time discussing today, and I don't anticipate that. But there are other very informal ways, including you can request a Type C meeting, bring us data, we can have a discussion about it, and let's have a back and forth conversation. Or you can even, you could even submit an NDA and go for it and see what happens. We're very reactive. We're forced to be very reactive, and so we rely upon investigators to bring data to us for discussion. So thank you.
Okay, thanks very much, Ashley. Janet?
So thank you also for the invitation to be part of the panel today, and but really special thanks to Jerry and his colleagues for doing this meta-analysis in ALL in terms of MRD. I think it really gives us a great platform in terms of additional confidence in terms of all the history we had with MRD and ALL, and having done so in such a robust way is very helpful to the field. When we think about ALL, we all know in this audience, of course, that it's a rare disease and there's still some unmet medical needs, as Jerry's already pointed out. And so when we think about ways that we are particularly poised in ALL or the ALL community collectively, whether you're an academician or from industry or patient advocate or whomever, in this group that's really keen in terms of what's happening with ALL and how can we make new advances to help patients, I think it's important to think of where we're at now and put it in context, because in ALL, as we've already heard from the other two speakers, it's used, and we feel like we understand a lot about how MRD should play a role in terms of making certain clinical decisions, or at least using it for some kind of prognostic predictors for patient decisions. And we see it already in terms of how it's incorporated in terms of clinical practice decisions already. Certainly clinical trials from some of the cooperative groups are using it in terms of some of their stratification factors. We know that the recommendations for treatment of ALL, talk about MRD in various forms in terms of how that might be an important factor to take into consideration. And we know that even when we talk about transplants, stem cell transplant, that's one of the active list of items that a transplanter will take into consideration in terms of at least the prognostic, chance of my transplant giving, a good outcome to a patient. So it's already being used. So this community, I think, is pretty primed in terms of MRD and how can we move it forward and how can it help for drug development. I think one of the things that struck me most with seeing the data from the meta-analysis was just the strength of the data in terms of its reproducibility across so many of the key patient factors and disease factors that we all look to in terms of trying to get insight in terms of a particular patient or group of patients, how they might perform. And so when we see that the MRD has a predictive value across gender, across a wide range of ages, we take in pediatrics and adult trials together, in terms of immunophenotyping, for example, all these factors are really important when you see that time and time again we're getting the same outcome in terms of predictive value. And certainly I was really struck in terms of the ability to show that MRD by flow or PCR still had prognostic value in terms of this population of patients. So that, to me, really speaks to the strength of the data and where we are in this field, and perhaps farther along than some of the other heme diseases we've talked about so far today. So I think that, when we talk about MRD and moving it forward and how can it be used to help us in terms of drug development and moving advances along to patients who need them, certainly we always want to have the appropriate benefit risk discussion and appropriate application of this to any drug that's being considered. But I think, I think we're there. I think we understand that's important and no one's going to walk away from that. But I think the issues of being able to incorporate this in a way that helps for accelerated approvals or regular approvals down the road is really important to how disease advancement could be made with new drugs. And certainly just applaud the effort that's been done so far to help build the field in terms of our understanding in this area. I think one last comment I wanted to make was I really was also wanted to kind of maybe repeat or even highlight how it spoke to me as a former leukemia doc as well before coming to Amgen, and how the issue about MRD is really about the disease itself and not a biomarker. It really struck me with that too. So thank you.
Janet, thanks very much. And next, Don.
Thanks, Mark. And like others, I want to thank you for inviting me. Unlike others, I want to apologize in advance for having to make you regret it.
That's never happened.
So you can tell from Jerry's presentation that I take a different perspective from what you've heard, and what I fear is the emerging consensus to this meeting. The trial-based versus the individual-based approach. Sumitra explained how in CLL they took 3 trials and split them into pieces by region, site, et cetera, so that they could have more trials. The limit of that approach, of course, is the individual patient. So I have some principles, as opposed to what others will tell you in this room. One of them...
I'll vouch for you.
One of them is that if you have to take individual data and put them together in order to make sense out of it, there's something wrong with your method. Nancy Valenti talked about the PCR, PathCR in breast cancer and the FDA meta-analysis and the FDA guidance for accelerated approval. The same issues arise there. The FDA, in their meta-analysis and in the guidance, did 2 different analyses. One was trial-based, where they looked at the randomized trials and looked at the benefit on pathologic complete response and the benefit on EFS and OS. They took 12,000 patients and compressed them into 10. There's something wrong with this picture, and they realized it, and they said very clearly in their discussion that there's something wrong with this trial-based approach. I'll summarize one of their issues. They saw, as Nancy said, they actually saw no benefit. The correlation was 0. It was actually in the wrong direction. Another principle is that if you don't have any treatment benefit, it's very difficult to show that there's a relationship between benefit on one endpoint and on another endpoint. And of the 10 studies, there were essentially no treatment benefits. There was one study that was kind of an outlier. So it's not surprising that when you draw a line, it's not going to have much of a slope. The patient-based analysis, however, and different from ALL, patient-based analysis within molecular subtypes were very different. One of the problems with that 10 trial plot was that it was mixing up triple-negative disease, which is highly sensitive to therapy, HER2-positive disease, which is sensitive to therapy, and luminals, which are not sensitive to therapy. So the critical issue, of course, is that a new therapy may not fit with the meta-analysis. If you come along with another therapy, it may have a different mechanism, and hence, as others have explained, the accelerated approval requires that you actually show that you have a clinical benefit. And the FDA, in my experience, has been very amenable to building into a trial, actually looking at both of those and seeing whether or not what you're getting in terms of a benefit on PathCR or on MRD negativity translates into EFS and OS benefits. And do it adaptively so that you update your model. Take the hypothesis that you saw Jerry present as a hypothesis in your designing a clinical trial. And maybe it's wrong. Maybe it doesn't apply in the trial. We'll learn if it's wrong, and we'll update it if we are getting other information. But it's a lot better, I can tell you, speaking as a biostatistician, it's a lot better than what we usually do, which is that we pick a number out of the air. You know, we're going to say clinically significant benefit of 25%. We're going to show that. Well, you know what it turns out to be. Almost never do we. This is a hypothesis that might not be right. We'll verify it more as we go along. There are some barriers, and one of them, first I'll talk about throwing a little bit of cold water on what you saw. You saw some amazing hazard ratios like 0.23 between MRD negativity and positivity. In an actual trial, of course, you're not going to get 100% change. You're going to get more like, let's say, a 20% change. That 20% change translates into, for a hazard ratio for EFS, 0.8. At 0.80, so a 20% reduction. So it's going to take, if you use that approach and you have a modest benefit, and if that hypothesis is true, it's going to take quite a large study. Is that minimal residual time cards?
That's all right. If you need to go on for another minute or two, that's fine.
So I'm now time card negativity. But the barrier is the attitude in the profession. And there's a very long story associated with breast cancer that I can tell you if you ask more. Nancy and others have said, you know, this was a great thing. And indeed, it was a great thing from the FDA. But the attitude, partly because of this trial-based approach and because of these two different perspectives, one of which was negative and the other was positive, threw all kinds of monkey wrenches in the community. There was a presentation at ASCO in 2014, plenary presentation on a trial that showed no significant benefit on 2,000 patients in each arm, no significant benefit on HER2-positive patients for a combination of lapatinib and trastuzumab. This was a trial called ALTO, in comparison with NEO-ALTO, which showed a statistically significant benefit on PathCR, 100 patients per arm. And this was taken by George Sledge, discussion, and there was moroseness across the breast community, because now we're going to have to do the large trials. If you looked at that thing that I just said, if you take 20% of the patients and move them from one curve to another, what do you suppose you get for a hazard ratio? 0.83. What hazard ratio did they observe? 0.84. I thought I was going to have to argue with George by doing simulations. It turned out the point estimate was smack on. That doesn't mean, of course, that the FDA meta-analysis is validated. It's only a sample of size 1, but it's an important contribution, and more data have shown, in fact, that it's validatable in the trial base. So I'll stop there. Thanks.
Thanks very much, Don. So next, Wendy.
Thank you very much, and thank you again for inviting me as well. I as somebody also similar to Jerry, who has spent much of my professional life hoping that minimal residual disease would be incorporated as potentially as a surrogate marker, I was very gratified to see the data that Don and Jerry and the group have generated. And I was particularly impressed by many of the things that have already been stated, that the techniques, at least for this frontline setting, did not seem to matter. that the molecular subsets don't matter. And I think that that's coming out even more recently with some of the new molecular subsets where there's, again, heterogeneity, for example, in the pH-like subset, about which there's a lot of talk and a lot of potential targeted therapies for the future. Again, MRD seems to discriminate there between who's going to be a good actor and a bad actor, even within this somewhat homogeneous subset. It just shows heterogeneity, and that MRD is extraordinarily predictive. I also think that I wanted to mention that there are a number of studies, and gratifyingly, I think we have started to move forward in terms of actually beginning to assess novel agents in the adult world of ALL using MRD as an endpoint, not as a primary endpoint, and perhaps we can move towards that. And there are a number of U.S. intergroup trials testing exactly that, incorporating the novel agents. And so I think it's a very exciting time in ALL, in adult ALL, where we can begin to see whether some of these exciting new agents will actually have a benefit and can be measured using minimal residual disease as a very important clinical endpoint. And finally, I just wanted to remark on the issue of relapse disease, which we really didn't discuss much. And I think here the issue about MRD is a little bit more confusing, because we have very, very high, with some of these novel agents, extraordinarily high MRD remission rates, negative remission rates of 80%, MRD negative with some of these new antibodies, blinatumomab, inotuzumab, and yet the progression-free survival is only 5 months. So clearly there's maybe a difference there, and maybe that's where some of the novel techniques, for example, next-gen sequencing, will come into play, where subclones maybe that you haven't been monitoring are the ones that actually are the ones that give rise to relapse. And I think we'll need to consider that carefully as we move forward. But I'm very hopeful that we can start maybe approving new drugs similar to what has been done in CLL and myeloma without MRD endpoints, with using MRD endpoints in ALL in the next couple of years, I hope. Thank you.
Okay, great. Thank you. I want to thank all the panelists for a very interesting discussion. I'd like to follow up on it with seeing if there are any comments that any of you would like to make based on what you've heard. And I'd particularly like to focus this on what are the next steps for MRD as a surrogate endpoint in ALL. This was the question that Ashley asked, and it was a good one. We had some good suggestions on the panel, including earlier consultation with FDA, trying to make sure that you're minimizing missing data and having analytics that are robust to the missing data in the analyses, and also some calls, I think, for that were there when in terms of time for using MRD as a surrogate endpoint in ALL, given the compelling meta-analysis that Jerry presented, and that Don worked. That must have been an interesting group to work with, Jerry, Don, for that study. But I think somebody basically said it was very. I think the general view on the panel was very compelling meta-analysis. So what do we do next? And maybe Don, if I could start with you, because I think your answer was from what you said was a bit different in terms of shifting to this individual versus trial approach. And I think that amounts to, as you said, including MRD as an endpoint, but in an adaptive design that also includes some of the traditional endpoints. Can you say a little bit more about, given the evidence, what we ought to be doing in trial design and further and approval decisions in this area?
Yes, Mark. So I should say a bit about the project. It was a project that was funded by the FNIH, the Foundation for the NIH, Gary Kelloff, Kim Jessup, David Woolley at the FNIH, and companies actually sponsored it. I'm not sure which companies they were, but maybe you know. And so it had 2 stages. The meta-analysis part had 2 stages. The project itself had 2 parts. One part was the meta-analysis. The other part was standards. And that's been led by some really able people that have made great progress and continue to make great progress. The meta-analysis was supposed to be 2 stages where we would do the literature-based and then do a individual patient-based. So we would go to the community and tell them about what we've done with their studies and try to get them to, in line with the stuff we were talking about earlier today, to submit to a database where we could analyze the data. And that was going to be stage 2, was the individual patient data. It turns out, and we presented to the FDA, wonderful discussion with the FDA, and they've sort of, and maybe Ashley can update us here, but they sort of picked up the ball and said, you know, we'll do the individual-based meta-analysis to get the individual data. And so they've already had some meetings on that with the people in the community. But the next steps are, I think, you know, I would, if I were a company, I would use this analysis replete with the uncertainties in those gray areas that you saw in the curves, but also the uncertainty in maybe a new drug or a new therapy, whether it's combination or what, is going to have a different EFS rate or OS rate, whatever is the ultimate survival characteristic that you can agree with the FDA, that you would use this to build a design, an adaptive design, that looks at the data, takes the appropriate statistical hits for so doing, and assuming that you can, I mean, this is helpful even if, as somebody indicated earlier, MRD is not a surrogate. It's a correlate, clearly, and you can use it to help in making for better trials. If it's a surrogate, the big deal is that once you pass that bar, let's say in the same trial, that you would get accelerated approval. And then if it's anything like the breast cancer guidance, you could do it in the same study. In fact, they say they prefer doing it in the same study, where you then follow those patients to see that you get EFS. So I think it's ready for using for that purposes, but also for, hopefully the FDA will proceed as they did with the breast cancer story. I'm not sure I answered your question, Mark.
No, you did. Just other comments about next steps or what you've heard?
I think even pre-FDA regulatory stuff, we should be thinking about how to use this in early phase 2 trials, I mean, and among the intergroups. I mean, there's no reason why. I mean, Don, you can educate me the best way to do this, but if you had A, B, and C new drugs down the line you want to try some type of adaptive design and say the MRD rates don't have to be better, but you can at least demonstrate that the data I suspect would be such that if you had drug A and it performed worse than the standard, you probably wouldn't be wanting to invest a lot in that one. Whereas if it's the same MRD rates or better, you might want to keep carrying that forward. Some way to filter out things that are promising versus things that are just dregs. There's a lot of dregs.
Other thoughts? Everybody clear enough on next steps? I'm not sure I heard a consensus. I heard some good ideas.
Maybe the companies out
say-
there can say what they would do as a next step. Would you use MRD and how?
Yes. Jump in.
Yeah, just press the button.
I'm a lead statistician at FDA, and I was just instructed by my boss. She was not able to come. So I just want to make some commercial. We are accepting the data right now, so if you are interested, you can contact Sridhara, Rajesh Shwara Sridhara. You can find her in Google them. Thank you.
Thanks for the comments. Other comments, as Jerry was asking, other comments from companies about how you want to proceed with using MRD? as you heard, FDA is open to accepting data. Yeah.
Two questions, one for Dr. Berry. Given your comments on the trial-based meta-analysis, can we conclude that you're not planning to go forward to look at a trial-based analysis of the ALL data?
I should say about these that there were some randomized trial in here. None of them we could have used in that trial-based comparison. We could, if we had the individual patient data, provided it was actually randomized. Some of the randomized trials weren't even random; were randomized after MRD. I didn't get any sleep last night. Say again what the question was.
That was the question. You got it.
Where are we going with the data? And is it going to be trial-based or not? So I'm probably not going to be involved in the individual patient data. That'll be read by Raji, you got me doing it. Raji Sridhara and others at the FDA. And they, in their initial phone call, Raji was sort of pushing the RCTs. And there was some pushback from the community, actually, as to the importance of cohort studies, and with members of the community, those who were voicing their ideas, said that these are as important as randomized trials. And so you'd ought to be looking at that. So I'm not sure exactly where that's going. Still up in the air. But the FDA, in line with their breast cancer meta-analysis, are interested in randomized trials.
The second question, right?
The second question for Dr. Sargent. I think I saw him come back, or Dr. Berry if he's not. Dr. Radich showed correlations between between MRD and EFS, and we're hopeful that at some point, someday, somebody will show a correlation between EFS and OS, so that we could actually validate EFS as an endpoint. But essentially what they're doing then, if I interpret this correctly, is looking at a surrogate of a surrogate. And so from a statistical point of view, is there a penalty in R squared when you have to do that? Or is there a one-to-one-to-one correlation?
So this is a favorite topic of mine. You know the thing that Dan showed that he didn't talk about? That happened to be PFS and OS, but we can't do that with our data. I mean, my pet peeve is that when people publish these things, they publish EFS, they publish OS, they may publish other characteristics, all marginally. So you can't put them together. You sort of suspect that they go together, and what we'd ought to be doing, and some people in this paper that Dan put up, we pushed looking at something we call survival post-progression, SPP, which is how long you live after you progress. And that is sort of a driver in the relationship between PFS and OS, or EFS and OS. I guarantee you there's a relationship between these, but I can't tell you, perfectly. I can't tell you what the disease-free survival is after you, what the overall survival is after you recur. But it's something that we've got to be doing.
I guess I would bring up to the clinicians in the group who take care of adults with ALL, how many patients do you have who have relapsed, who didn't get a transplant, who are still survive 5 years out? I mean, the Joan Mortimer data was something like 2%, as I recall. So it's pretty unusual.
Dan?
Sure, I'll just add a couple comments. So in terms of surrogate of a surrogate, yeah, that's actually what we did in our FLASH analysis, because the endpoint that was accepted based on OS being so very long in follicular was PFS. And so we actually identified CR at 30 months as a surrogate for a surrogate. Does the bar have to be higher in that circumstance? Probably so, if you're a surrogate for a surrogate. How important, as with everything, there's surrogates and there's surrogates. How clinically meaningful is the surrogate? For example, PFS. I think PFS has clinical meaning in and of itself, regardless of whether it's a surrogate or not. So in that case, if we have CR30 as a surrogate for something that, in fact, in FL, PFS has never been shown to be a surrogate for OS, actually. It just is the accepted endpoint. We're going to actually look in FLASH as we get more and more studies at the relationship between CR30 and overall survival, but at this point only the PFS was mature within FLASH. So we always need to look for the correlation with the overall endpoint. That's critical. Just in terms of the trial-based versus the individual-based, I think they're complementary to each other. We're talking about endpoints for accelerated approval, but also endpoints for full approval. And so at the individual patient level surrogacy, that is been accepted by the FDA that a correlate reasonably likely to predict clinical benefit would be appropriate for an accelerated approval. When we're talking about full validation of a surrogate, which really was what I was talking about, was more aimed at allowing a full approval based on that endpoint, which I think there is still critical to assess at the trial level. And we do better modeling. It's just not reduced to 10 points, as Don knows. We fit a bivariate model with an association parameter and do take advantage of all the data. But that really allows the assessment of the treatment effect on the true endpoint and demonstrates the reliability of the prediction. So if, at least my expectation, my experience in colon cancer, the practice was through the trial level analysis, we were actually able to validate a surrogate as an endpoint for full approval.
So you're talking about next things forward. So we have to get this paper out, and then I think when the FDA does their single, individual patient analysis, it's hard to me. It'll fine-tune things. It'll hard for me to believe that it will negate the data that we've shown so far. And if that's true, then I think the door is really going to be open to people to use it. Like I said, the CML, we started using these things as a marker, and the data was way less strong than the data in ALL is. Way less strong.
And that seems to be, Don, would you agree with that assessment too in terms of where we go from here? I mean, this is an important distinction that Dan's making between MRD for full approval and MRD as an accelerated approval, especially embedded within a trial design that follows up on the individual level PFS and OS outcomes.
Yeah, so with respect to that, it's the accelerated approval will certainly apply for some period of time if the FDA agrees with accelerated approval, but it's only after, think about CD4 counts in HIV. It's only after you learn that therapy after therapy after therapy, the same thing applies, that it becomes a surrogate that for full approval. I want to mention an analysis that I did along the lines of what Jerry just said. After the FDA did their analysis in breast cancer, I did a meta-analysis published in JAMA Oncology in HER2-positive breast cancer, updating the FDA, but also adding in cohort studies. And what do you suppose? We saw for the randomized trials, we saw a 0.4 for the hazard ratio for the randomized trials. For the cohort studies, which were much bigger in number and in number of patients than the randomized trials, we saw 0.33 actually. So confidence intervals overlapping, but the same thing we saw in the cohort studies. Along these lines of the surrogate becoming a real full approval endpoint, there's a famous case in breast cancer, metastatic breast cancer, that you probably read about that gave the FDA all sorts of problems. Avastin, which showed bevacizumab, which showed huge benefit on progression-free survival. And then, in the same studies, overall survival almost zip. And so they withdrew their accelerated approval, much to, with I'm sure, lots of difficulty and consternation. It probably has to do with the mechanism. So VEGF inhibitors, for example, such as Avastin, might have a different response. Maybe it has an effect on lowering the tumor burden that's observable, but what's hiding in the bone marrow may not be affected. Or maybe it's the stem cells, but whatever it is, you're affecting the observable part of the disease, but not the real disease.
Yes, go ahead, Janet.
So going back to an earlier question, in the absence of other industry voices speaking up, we'd like to say that certainly we've appreciated the guidance we're getting today from FDA and other opportunities to speak with FDA on this topic, because we have indeed, in the case of Amgen, looked at MRD positive ALL and done 2 clinical trials, single-arm trials, however, but nevertheless looked at this in terms of being able to show conversion of MRD positive to negative in a population of patients, and also being able to correlate, at least in the second study that we presented at ASH recently, well, I guess 10 months ago now, in terms of relapse-free survival, distinction of those 2 groups. So again, we look for the guidance because, as I'm hearing today, the issues about looking for data gaps, looking at, what are the next steps in terms of other data sets that might be needed to supplement that or complement that in terms of an approvable pathway. Mm-hmm.
Thanks, Janet. Other comments or questions? Yeah, go ahead.
Jerry, this is the Jerry and Wendy. As a drug developer, let's say this is helpful for big phase 3 studies in the upfront setting, but what about using MRD as a way to get new drugs approved, getting patients to transplant? Because you're never going to get that in a surrogate to a surrogate that's curative, and because that's really the big barrier in adults that relapse, is getting them to transplant.
So using the indication as a bridge to transplant.
We know that if you go into transplant with less disease, you do better.
Yeah.
And that is a surrogate to a curative outcome, because it's very challenging. You can have beautiful antibodies and targeted therapies, but if the patient population is small and there's not a clear defined path, because everybody that benefits goes to transplant and they're censored, so they don't count favorably in your analysis for favorable benefit. And so, do you see MRD coming in that setting as you've talked about in the upfront setting?
Well, I think that's the underlying statement of blinatumomab, right? Is to get people into, I don't know if anyone thinks that those drugs are going to cure people forever, but get someone who's MRD positive, turn them into negative so they can actually get the transplant. Because like you said, if you transplant when they're MRD negative, they do pretty lousily. Now, we don't know if forcing someone to negativity is the same as someone who falls into negativity by themselves. I suspect it's not, but I would sure rather go into transplant being negative by any means than going in positive if I was a patient. I'll take my chances with that.
It's also a question to Jerry. So you mentioned the model of MMR and CML as an example how maybe ALL should go. So could you comment on lesson from the recent dasatinib trial, which showed improvement in MMR but no difference in PFS?
Yes. So it's very interesting that there's been a few cases. Well, first off, one good thing about using MMR for the dasatinib and nilotinib trials for registration was that if you wanted an improvement of survival, you could have never done the study because the survival is at 85% with imatinib. So you would have had to have an outbreak of avian able to get enough CML patients to ever do the protocols. That was one good thing. And yes, you say the MMR rates are different in those trials. Long-term survival so far isn't. There might be a little bit of signal in nilotinib. And I don't know if that's because the effect is going to be smaller or if there's just not enough N. But the real good part of that unintended consequences is that the people who get a MMR tend to have a much higher rates of getting into CMR, and then it can get discontinued. So while the patients who got nilotinib and dasatinib, there's a difference in the MMR compared to what Matt did. There's not a difference in survival, but the rates of people who go into a deeper response are way higher, like double. And those patients, a lot of them are going to get off drug. So it had unintended consequences of having being an outcome that no one ever anticipated at the time of the trial.
Thank you all for the questions and comments. Any final thoughts from the panel? Really interesting discussion. As always, I'm very glad to invite Don. Yeah, you need some sleep. All right. Thank you all very much.
Thanks.
Thank you. Great. All right, we're going to go right into our final panel of the afternoon, so I'd like all of the panelists to come on up.